I'm looking at that.
Hello, my name is Consuelo Gonzalez Salmeron. I'm an undergrad student at Columbus State University. I've been a nurse here at Northside Gwinnett for about 2 years. I've been working in the area of cardiology in telemetry, and recently just started my residency in CV-ICU. Today, I want to thank you for joining me and thank you for listening to my presentation. This is part of my senior project at Columbus State, and I'll be talking to you about decreasing CLABSIs in the CV-ICU. First of all, what's a central line? A central line is an intravenous device that ends close to the heart or sits right next to a heart vessel, as you can see here in this picture. The most common sites where these central lines are placed, we have the subclavian vein, the internal jugular vein, and the femoral vein. The statistics on CLABSIs in the United States, there are an estimated 80,000 catheter-related bloodstream infections with 28,000 deaths every year. The average cost for a care of somebody with a CLABSI is $45,000, and the total annual expenditure is $2.3 billion. Here on this chart, you can see how a CLABSI in comparison to a CAUTI, that's only $2,000, but a CLABSI, it can range all the way, the medium is $37,000, with the high end being the $45,000. So you can see how important it is for hospitals to decrease CLABSIs because it costs a lot of money to treat a CLABSI. It doesn't compare to just like a Foley-related infection. A central line is costs a lot more money. Now, what are our stats specific to our CV-ICU? They range. Last year, several months we were at 3%, and a couple months we landed on 6%. Although the numbers don't seem high, if they cost $45,000 and the medium range is $37,000, even a 3% hit on our unit costs a lot. So we want to address that. Central line associated problems. What are some of the common causes that central lines can cause? As you can see on this slide is obviously bloodstream infections, and that is where our focus to this PowerPoint will be, but they can also cause thrombophlebitis, endocarditis, and local site infections, such as the skin where the central line is placed. CLABSIs, what do they cause? They cause increased mortality rates, increased length of hospital stays, increased hospital costs, increased strain on both nursing and management, and negative feedback from our patients and family members. When patients leave with a experience at CLABSI after coming in for a another procedure, they don't leave with a very good image of our hospital. They're going to blame it on our hospital and on our care. Also, CLABSIs result on a very, very, very sick patient, like you can see in this picture. What are signs and symptoms that we need to look out for when we have a patient experiencing a CLABSI? We're going to be looking out for redness at the site. That's why it's important to do your assessment of the site when you have a patient with a central line every day that you have that patient. That should be one of your first priorities. They might have some swelling, or it might just be warm at the site. So you want to make sure you're putting your hands on it, of course, after you do your hand hygiene and with your gloves, and you're feeling for that warmth. They might have some yellow or green drainage, pain or discomfort. Some patients may or may not have fever and chills. On their labs, you will see a jump on white blood cell count. They'll have poor flow. So when you're going to give them a medication or you're going to draw blood, you're going to feel some resistance. That's an early sign of a CLABSI. And to diagnose a CLABSI, you will have some positive blood cultures. Catheter contamination is the #1 reason patients experience CLABSIs. Some of the modes of transmission are hands of patients, doctors, and nurses. Contaminated IV infusions, other remote infections such as UTIs, a break in aseptic techniques during insertion. The problem in CV-ICU, lack of nurses' abilities to speak up, and this is specifically to our unit, and inadequate protocols. So on our unit, we don't have the latest protocols. We're not incorporating those into our bundles. And when I say lack of nurses' abilities to speak up, I'm referring to two examples. One is when the doctors are inserting these lines at bedside, sometimes they break sterile field, and many nurses are afraid to stand up to that doctor and say, you broke sterile field, we need to start all over. We've seen that here, and also the inadequate protocols. We're not doing the up-to-date evidence-based studies on our bundles of care. The problems continued. We have unnecessary daily access to our central lines, and I'm going to be explaining this further on my PowerPoint. Hand hygiene. We're not cleaning central lines thoroughly with CHG wipes. Although we're doing really good putting on those green Keurig alcohol caps, we're not cleaning each line with CHG wipes. We're not scrubbing those hubs for 30 seconds prior to using the line, and we're not letting it dry for 30 seconds. Another issue that we're having on our floor is, although our surgeons and our floor is used to keeping central lines for 7 days, it doesn't necessarily mean we need to keep them for 7 days. If we have a patient, they're on day 4 or day 5 and they have not had any rhythm issues, and there's a low likelihood of having to administer amiodarone, that's something that we need to start to look at. Because the longer the length of stay of that central line, the higher the risk of that collapsing. The solution to the problem, I've come up with 4 solutions. We need to approach this as a whole unit. We all need to be in unison. We need to approach it using best practice. We need to have standardized techniques where one nurse doesn't deviate from another nurse. And of course, bundle approach. We've got to do the central line in a bundle. Solution number 1, I'm suggesting 3 different bundles. We should have an insertion bundle, a daily catheter care bundle, and a dressing change bundle. The following 3 bundles were an incorporation of the 4 articles noted on this PowerPoint. We have an insertion bundle here that we're supposed to follow. I have highlighted areas that we need to work on in red, so I won't go through everything because there's a lot. This would be a full printed out checklist. The first item is we don't have a checklist. When a doctor comes to bedside and they're putting in a central line, nurses are just winging it. The doctor's asking for kits, he's asking for this. We don't have a standardized checklist that we can use, and that way we can have everything at bedside. So that would be my first suggestion. Also, we don't have a designated nurse not participating currently in the procedure. Now, this can be lack of staff, it could be a whole hospital institution, but on our floor currently, when a doctor is inserting a central line, the primary nurse, half the time is the one observing, and she's also helping hand instruments to the doctor or supplies. We can't have that. We need to have an observing nurse that's not participating, and their primary job is to stop the doctor if he breaks a septic technique or anybody participating in the procedure. We're doing great with hand hygiene. We're doing great with prepping the skin with chlorhexidine, but where we're not doing good is stopping when we see a break in sterility. We have awesome insertion kits. We have a cart available there for additional items needed. We're doing great with the maximum sterile barriers. What I have seen though is that doctors are not wearing goggles. Now, we always worry about protecting the patient, but in this case, this is an area where we can help protect ourselves. When we go to insert a line, there can be some fluids that may land on your face, so MDs or any nurse standing more than 2 feet away should be wearing goggles. Last, the checklist should specify some important highlights such as the stats of using the femoral vein to discourage MDs from inserting a line at the femoral site. And of course, we're doing very good with our labeling after insertion. For our maintenance bundle, I have highlighted some areas in red where we need to work on. Of course, we would incorporate that checklist strictly for the maintenance bundle. We need to start communicating with our primary team. We need to switch some of these IV medications to oral. I have seen patients downgraded to telemetry and their diuretic is still being administered IV. If the patient can swallow, they can have their Lasix in a tablet form. So this is something where the nurse can initiate that change. Also, we are using central lines a lot. We're accessing them without having to access them. We have orders to give for a lot of our patients Solomedrol, and it's 0.5 of an ml. And we have nurses giving that medication through a central line. For 0.5 of an ml, it is not necessary to access that central line. We have peripheral lines that can tolerate 0.5 of an ml. So that is where I would challenge our floor to work on that. Also, I have a YouTube link here based on the most current evidence-based practice. Basically what this YouTube video does is something we're currently not doing on our floor. We're doing very good with bathing our patients and cleaning them with the CHG wipes, but we're not taking the time to clean each port with a CH wipe. And unfortunately on our floor, we don't carry the smaller CHG wipes. They look like alcohol pads, but in the latest study is you would clean the patient, you would bathe the patient around the central line with a big CHG wipe, and then you would take each port and you would clean with an alcohol size, like the little 5x5 prep, and you would actually have to clean each port. The Curals caps being on there, that doesn't make your port clean. Before you give an administration, you have to scrub it with an additional CHG wipe. That Curals port is just there for an extra added feature, but it's not gonna clean it for you, and so we need to work on scrubbing those ports. Last, we need to have a goal sheet. We need to work on the length of time. Right now, we're averaging 7 to 8 days. A central line should not be in for longer than 7 days, but yet our averages are 7 to 8 days. So we need to work on cutting that. And here I would also challenge our clinician. Our software has that capability of tracking where we give medications. We just go in there and we put the site. So here she could quickly run a report and she can let us know how many times we access the central line when we could have given an alternate method of medication. And last is our dressing changes. This is where we are doing the best. The only thing I would change is we would add a checklist specific for dressing change, and we would need to pull in an observing nurse. We're currently doing the dressing changes on our own, and if we break sterility, we don't have somebody to run out and grab a new dressing for us. And again, dressing changes need to happen every 7 days, or PRN in the area that we lack.
Yeah, we'll be all right. Keep going.
Keep recording me. So let me just fix that. Sorry. We have, as you all know, we have the COVID crisis on our unit. So we're not allowed to have more than 10 people. And we were not authorized to use the conference area. Those are off limits because we are trying to decrease the amount of people that go into rooms that had more than 10 people in them. So this is Jessica. She just joined us. She's another RN. She had to run to a rapid code, but we will fill her in and we will share this PowerPoint with her after. So an area that we need to work on for dressing changes is our PRN. So many times I come, I get a patient and their central line dressing is hanging halfway out. That is a direct way that they're gonna get a bloodstream infection. We are leaving it open and we're leaving them susceptible. So we need to work on that. And like I said, if it's in red, these are areas that we need to work on. If it's in white font, this is something that we're already doing a very good job on, and we are already up to date on our current protocols. The solution that I am recommending is I just want to empower nurses and the staff to stop procedures if they notice a break in sterility. And the way I would do that, and I would achieve that, is by introducing the Speak Up campaign, in which we would train nurses with simple verbiage that they can use with MDs that have proven to be adequate. And this would cause the MD to be responsive to those halts, and they would stop and they would make a correction prior to the insertion. Also, I would like to introduce the use of technology. We have technology there. It's very easy for our clinician to track how many times we're accessing these central lines, like I mentioned before, because we go in there and before we give a medication, we tell it, where we're giving that medication. So she would run this report weekly, and she would be able to tell us how and what areas we could decrease on, what medications can be given peripherally versus having to access that central line. How do the latest central line protocols help prevent CLABSI rates when applying new evidence-based practices in comparison to outdated protocols? Where here's the data. As you can see, when hospitals adapted these bundle cares, and the nurses were performing the bundle cares to maintain them during insertion and during dressing changes, the CLABSI rates, they almost went off the chart. They were not even visible. So we can obtain a 0% CLABSI rate if we stick to these bundles and adhere to them at 100%. Also, management needs to recognize that we have a problem. We need to raise awareness within the department, and we need to identify who our role leaders are. We can't just expect all the nurses to go out there and make this happen. So we would identify a couple role leaders that would help with education. And like I talked about before, we would have the speak up training campaigns to help us with the verbiage to use with our MDs, and we would make printed protocols available for all nurses, and that would highlight any changes to our current bundles. The results, a comparison of 2013 with 2017 showed a 69% of decline in a number of CLABSI cases when they adapted the latest evidence-based CLABSI care. There was a 30% decline in CVC days from years from 2014 to 2017. Over the same period, CLABSI events per 1,000 central lines decreased from 0.6 to 0.362. Within a month, central lines need to be reduced by 50%. Central line access.
I'm sorry.
It's okay.
Jessica, can I help you?
So that's what we would hope our results are for our unit, that within a month of tracking the central lines, that we would decrease that access by 50%. Our evidence-based research should also help us. We're gonna move that 3 and 6% to 0 or 1%. So that's what we hope for our results. And last, I just wanna thank you again for sitting here and listening to my speech. Do you guys have any questions?
Is there a criteria in which you pull a central line if you thought that the suspected a CLABSI?
So yes, so there is a criteria. First of all, you obviously want to notify the provider because there might be a contraindication to not pulling that. For example, a patient they might have a CLABSI. We were going to do these cultures. So the criteria is we do 3 different types of cultures and we try to rule out, is it really bloodstream related? So we're going to have your respiratory cultures, we're going to have your urinary cultures, and we're going to have your blood cultures. So depending on what that shows, then we will see, okay, is it really a CLABSI? Now, the patient can have other issues or other comorbidities. For example, they can have really low blood platelets, or they can have some fibrinogen issues where their clotting factors are out of whack. In that case, we have to choose, do we have to immediately remove this CLABSI, or is the patient gonna bleed to death? So there will be some criteria that even though we have CLABSI events, we won't be able to pull that CLABSI, that central line. Very good question. Any other questions?
No.
All right. Thank you, ladies.
Thank you.
You're gonna edit your thing. You can edit it, right?
No?